Today, we are going to break down exactly how to diagnose and treat community-acquired pneumonia in the outpatient setting.
So here's our game plan. This follows the exact thought process you're going to use in the clinic. First, we got to nail down the diagnosis. Then, we make that huge decision. Can they go home or do they need to be admitted? After that, we get into the real meat of it, choosing the right antibiotic. And finally, we'll wrap up with the details: dosing, how long to treat, and how to follow up to make sure everything goes smoothly.
Okay, first things first. Before we even think about writing a prescription, we have to be absolutely sure we're dealing with community-acquired pneumonia, or CAP. Let's build that solid foundation for our diagnosis. You know, the key is right in the name: community-acquired. This isn't some bug they picked up in a hospital or a nursing home. We're talking about someone who was just living their life out in the community and then developed this acute infection down in their lungs.
Now, this is the formula you've got to burn into your brain. You need two things. One, a clinical story that fits, fever, cough, shortness of breath. And two, and this is the non-negotiable part, a new infiltrate on a chest x-ray. The major guidelines are crystal clear on this because, let's be honest, symptoms alone can look like bronchitis or a bad flu. That x-ray, that's what clinches the diagnosis.
Okay, so you've officially diagnosed CAP. Great. Now comes the first really big decision point. Can this patient safely go home with a script, or do they need a hospital bed? And this is such a key question. Yeah, we've got scoring systems to help us judge how sick someone is, but your clinical judgment has to go way beyond just the numbers. What are those real-world things you need to think about before you can feel good about sending someone home? You have to see the whole person, right? Can they actually keep fluids and pills down? Are they going to remember to take their medicine 3 times a day? What if they have cognitive issues? Or maybe they're homeless and don't have a safe place to recover? Look, a perfect antibiotic plan means nothing if the patient can't actually follow it. These factors are absolutely crucial. All right, now we're getting to the heart of it. Your patient is safe to be treated at home. The question is, what do you prescribe? This is all about picking that initial, or empiric, antibiotic, without actually knowing which specific bug we're fighting. So our strategy here is to use a broad net to catch all the usual suspects. We're definitely targeting strep pneumo, that's the most common culprit by far, and also H. flu. But, and this is important, we also have to cover the so-called atypicals, like mycoplasma. They're called atypical because they don't have a normal cell wall, which means our go-to antibiotics, like amoxicillin, won't touch them on their own. What's really great about this is how it simplifies things. Your decision-making process basically starts by putting your patient into one of two buckets. Are they pretty young and healthy with no other issues? Or are they older, or maybe they have some chronic health problems or took antibiotics recently? That one question is going to guide your whole therapy. So for that first bucket, the healthy patient, we go with a 2-drug combo. The backbone is high-dose amoxicillin, and we use that high dose for a very specific reason: to blast through any potential resistance from strep pneumo. Then we add a second drug, either something like azithromycin or doxycycline, and that's our coverage for those atypical bugs we were just talking about.
Now, this is a really important nuance. If you read the official guidelines, they'll say you can use just amoxicillin alone for these healthy folks. But in practice, a lot of us will always add that second drug for atypical coverage. And the thinking is pretty simple. We can't tell just by looking at the patient if it's a typical or atypical pneumonia. And the risk of adding a short course of doxycycline or a Z-Pak is super low compared to the risk of missing something serious.
Okay, now for our second group of patients, the ones with comorbidities. Here, we level up our main antibiotic. Instead of plain amoxicillin, we use amoxicillin clavulanate. You can think of the clavulanate part as a bodyguard for the amoxicillin. It stops certain bacteria from breaking it down. And, of course, we still pair it with either a macrolide or doxycycline to get that all-important atypical coverage. Sooner or later, you're going to have a patient with a penicillin allergy. No problem. For a mild allergy, a cephalosporin is a great choice. If it's a really severe anaphylactic type allergy, then you can reach for a respiratory fluoroquinolone like levofloxacin. But, and this is a big but, we keep those in our back pocket. We reserve them because of side effects and resistance concerns. So, you've picked your drug. Awesome, but we're not done yet. Getting the choice right is only half the battle. Now we've got to fine-tune the prescription and make sure we get the dosing, duration, and safety checks just right.
This quote right here really hits the nail on the head. It's exactly why we're so careful with those fluoroquinolones. Every time we use one, we're contributing to resistance. But it's more than that. These drugs have serious black box warnings for things like tendon rupture, and they're notorious for causing C. diff infections. They are powerful, no doubt, but we have to be really smart about when we use them.
Here's another critical safety check. Before you hit send on a prescription for a macrolide or a fluoroquinolone, you have to do a quick mental check. Both of these drug classes can mess with the heart's electrical cycle, the QT interval, and that can lead to a dangerous arrhythmia. So ask yourself, is my patient elderly? Are their electrolytes okay? Are they on any other meds that do the same thing? If you're checking off multiple boxes, it's much safer to use doxycycline for your atypical coverage.
So, how long do we need to treat? You're going to love this answer. It's probably shorter than you think. For the vast majority of outpatients with CAP, 5 days is all you need. But, and this is a big but, that 5-day rule is not set in stone. It is completely guided by how your patient is doing. You can only stop at 5 days if they've been without a fever for at least 2 full days and they're clearly getting better. If they're still feeling lousy, you'll need to extend the course and maybe rethink what's going on.
All right, last section. The prescription is sent. Your job isn't over. Now comes follow-up. And just as important, managing your patient's expectations about how they're going to feel over the next few weeks.
This timeline is your best friend for counseling patients. Seriously, consider showing it to them. The fever? That should be gone in a few days. But that nagging cough and the fatigue? That can easily hang around for 2 weeks or even longer. About a third of people will still have at least one symptom a month later. Setting this expectation up front will save you and your patient a lot of worry.
So this is a question you're going to get a ton, both from your patients and maybe from yourself. Once they're feeling better, do we need another picture to prove the pneumonia is really gone?
The simple answer is no. For a patient who's back to feeling normal, a repeat X-ray is just not necessary. Why? Because the changes on the film can take weeks, sometimes months, to disappear, long after the infection is cured. Remember the old saying, treat the patient, not the X-ray.
And there you have it. That's our guide to outpatient pneumonia. But I want to leave you with one final thought. This framework we've talked about is your foundation, but the world of infectious diseases is always changing. Your job isn't just to memorize these rules, but to be ready to adapt them as new bugs and new resistance patterns emerge.